Good morning, everybody. Thank you for joining. My name is Kevin Alby. I'm Associate Director of Clinical Microbiology at the University of North Carolina Medical Center and Assistant Professor of Pathology and Laboratory Medicine at the University of North Carolina School of Medicine. And today I will be talking about meningitis and encephalitis, some overview, some epidemiology, and what our current diagnostic methods are. The objectives for today's talk are to describe the difference between meningitis and encephalitis and the challenges with diagnosis, to describe the most common causes of meningitis and encephalitis, and to describe the diagnostic tools used to diagnose these two diseases. Meningitis, estimates for bacterial meningitis are that there's somewhere between around 4,000 cases annually and 5,000 deaths in the U.S. The leading causes of bacterial meningitis in the United States are Streptococcus pneumoniae, Group B streptococci, Neisseria meningitidis, Haemophilus influenzae, and Listeria monocytogenes. Viral meningitis or aseptic meningitis is also very common. However, the exact frequency is very difficult to calculate due to insufficient diagnostic testing. And this is something that will come up several times throughout this presentation, and including in a few slides. Like most diseases, there are a number of national organizations devoted to increasing awareness of meningitis and encephalitis. This particular poster is taken from the National Meningitis Association, which gives just some of the classic signs associated with bacterial meningitis and things to look for. Encephalitis, similar to meningitis, a large number of cases do not have an etiologic agent, and bacterial, viral, fungal, and parasitic causes have all been documented. There are also a number of non-infectious causes for encephalitis that have been described, and one of the main differences distinguishing between meningitis and encephalitis are some of the altered mental status abnormalities that you get with people who have encephalitis. Things like memory problems, loss of taste and smell, personality changes. These are all evident. Some or all of these may be evident in patients who have encephalitis. To distinguish between meningitis and encephalitis, there's a few basic definitions which are, again, one way to differentiate between these two diseases. So from a strict definition standpoint, meningitis refers to an inflammation of the meninges, and these are the membranes that surround the brain and spinal cord. The classic symptoms associated with meningitis are a very significant headache, often described as the worst they've ever had, and then trouble or pain when moving the neck. So that's the stiff neck, is again one of the classic signs of meningitis. Encephalitis refers to inflammation of the brain itself. And so, as I was saying before, the hallmark attribute for encephalitis would be altered mental status. To muddy the water even further, there are other diseases which are associated with inflammation within the central nervous system. And these include myelitis, encephalomyelitis, meningoencephalitis, which, as the name might suggest, is a combination of both meningitis and encephalitis, and leptomeningitis. So how does one go about evaluating a disease such as encephalitis? If you look at the IDSA guidelines, there's a very large table, part of which is displayed on this slide here. And you can see if you zoom in and enlarge the font, you can hopefully see that there are a number of tests depending on what etiologic agent you think may be causing the disease. And so this is not meant to be an exhaustive slide showing all the different ways, but just, again, an overview of the complexity that may be involved in testing for these patients. So as I talked about a few slides ago, if we look at the U.S. For the epidemiology of meningitis and encephalitis, you can see that we have a wide variety of causes. And so if you look at, approximately 20,000, a little over 20,000 cases over a 3-year period, you do have a number of viral positives. So enterovirus was positive in a number of cases. You have a large number of bacterial, again, that 3,600, so around that 4,000 cases of bacterial meningitis. But you have a large number of unknown etiologies. So in this case, about 5,000 were unknown. And that's actually really good for looking at the kind of incidence of actually finding a causative agent. You'll see from kind of some additional slides that the unknown etiology tends to be a lot larger in terms of percentage. And we'll come back to this slide and what it means to, if we find something, how that can affect the duration of antibiotics and antimicrobial therapy. So looking at a long trend over bacterial meningitis by different organisms in the United States. Again, the most common ones being Streptococcus pneumoniae, Neisseria meningitidis, Haemophilus influenzae. But you can see what the impact of the pneumococcal vaccine and the meningococcal vaccine have had. So if you look at the introduction of the pneumococcal vaccine around the year 2000, you can see that, pneumococcal meningitis was, maybe starting to head downtrend a little bit, but you saw a distinct downtrend in pneumococcal meningitis after the implementation of the vaccine and sustained drop in incidence. Similar with meningococcal meningitis, to the point where actually meningococcal meningitis has dropped below kind of general gram-negative meningitis and staphylococcal meningitis over the past couple of years, so it's actually a less common cause. Why is that important? Because the change in epidemiology, again, changes how we think about what we should do for diagnostic modalities. Where you acquire the disease has a significant impact on what type of organisms is causing the disease. We know this for a lot of infectious diseases, and the same is true for meningitis and encephalitis. So in this particular figure, we're looking at community onset meningitis by analyzing 600 patients in a Houston hospital over a 6-year span. They looked at both, they defined the patients, whether they were acute or subacute based on how long they had their symptoms, and they looked at where they found the organisms. So, what I was alluding to earlier about how frequently the etiology is unknown, here's a much more common figure. So at the top line, you can see that our unknown percentage is around 70% for the acute patients and about 65% for the subacute patients. So again, a vast majority of cases do not have a defined etiologic agent for community onset meningitis. Bacteria were relatively common, so about 10% of cases, with things like Streptococcus species, which would include Streptococcus pneumoniae, being the most prevalent. So this kind of fits with what we have seen, a smattering of other bacterial species. You can see viral etiologies down there, with HSV making up the majority of kind of those viral cases. What you'll see as we go through is that there's a few different viruses that switch in terms of their etiological prevalence, but HSV and enterovirus tend to be up near the top, while other viruses such as West Nile, St. Louis virus, and things like that tend to be a little bit lower. Depending on the patient's underlying conditions, some of the fungal etiologies such as Cryptococcus and Histoplasma then become, potentially more relevant and more prevalent. This is in contrast to healthcare-associated neuroinvasive infections, and this is really focusing more on the bacterial causes, but what you'll see is that you have a large number of gram-positive organisms that are not streptococci. So, the previous slide, again, the vast majority of the bacterial isolates were Streptococcus pneumoniae. You had one MRSA, so no coagulative staph. So these agents do not cause community-acquired meningitis. However, they are very highly associated with healthcare-associated neuroinvasive infections in adults. And so something that we need to consider is, again, what is our patient's background? What is their history in terms of healthcare? exposures in terms of trying to think of what organisms should we be looking for and how should we be looking for them. In terms of aseptic meningitis for children and adults, you can see here, because we don't have a good idea of what else could be causing a meningitis, so we have a negative bacterial culture, we need to do some other testing. It's a kind of a mixed bag in terms of what people end up doing. You can see HSV PCR, herpes simplex virus PCR being performed quite frequently, tends to be positive more frequently in adults as far as looking at meningitis. Encephalitis, you may see that skew a little bit more towards children. You can see enterovirus being more prevalent in children than in adults, with kind of a rare other virus here or there. But again, if you look at the bottom line, you look at the unknown etiology, and you see 86% in adults, 61% in children have an unknown etiology. So to kind of focus in on that kind of finding of enterovirus and parocavirus in children, this is a study that looked at 285 children with suspected enteroviral infection, and they looked at what are the best ways to diagnose enteroviral meningitis. So if you look at the figure on the top right, you can see for enterovirus, the sensitivity of real-time PCR was about 85% with perfect specificity and a high negative predictive value. Viral culture was very poor at about 28%. Paracavirus had a similar result for CSF PCR, and owing to the difficulty in isolating and identifying paracavirus in culture, you can see that there was actually no positives detected via viral culture. In patients who have meningitis, you can actually find the virus in a lot of other sample types. But again, the unique thing here is that PCR is clearly a superior source. It's clearly a superior test in terms of sensitivity. The specificity can sometimes be hard to determine because what is your gold standard? What is your true positive? And so what does it mean if you find positives in patients who have meningitis with no cause or no identifiable cause, but you find enterovirus in the stool or in the urine? Like, how do we interpret those? That's some of the diagnostic dilemma. Clearly, they have a lot of the virus present. Could it be associated with their symptoms? It's hard to definitively tell. Arboviruses are frequently something that we think about every summer. They tend to make the news, and are a very important cause of meningitis in the United States. Meningitis encephalitis in the United States. So this particular slide looks at the incidence of various neuroinvasive disease classifications of arboviruses. Far and away, West Nile is the most prevalent and most common arboviral infection in the United States. A smattering of other viruses do crop up from time to time throughout the country: La Crosse virus, Powassan virus, Jamestown Canyon virus, St. Louis encephalitis virus, Eastern equine encephalitis virus, and in this particular one, there were some unspecified California serogroup viruses. They ebb and flow every year, though, in terms of kind of the overall prevalence, where they're being found, and things like that. So, if people have been listening to the news this year, Eastern equine encephalitis virus has been popping up a lot more this particular year in the U.S. than it has in others. We can see that from kind of West Nile over the past few years, and look at comparison of 2014 to 2018 in terms of the incidence of West Nile virus. You can see that in 2018 was our highest year in terms of neuroinvasive cases. Also our highest year in terms of non-neuroinvasive cases, but a relatively normal year in terms of viremic blood donors. So again, it's kind of some interesting data looking at kind of the prevalence of this disease and how it ebbs and flows over time. And so you can see, 2015 was another relatively high year in terms of mortality from West Nile virus, but 2016 wasn't as bad by some of the metrics. There are always other things to consider. So I haven't talked a lot about fungi, so things like histoplasma, other bacteria, Mycobacterium tuberculosis, especially in other parts of the world, is a huge cause of meningitis, but something maybe not as prevalent to the U.S. audience. If we have indwelling devices or specific zoonotic exposures, again, other bacteria rise to the list. We've all, are all familiar with fungi that pop up kind of via iatrogenic outbreaks. Fungi are in our environment and can occur, causing meningitis and encephalitis. And then we have other things to consider, like this molecule here, which is our NMDA receptor. And so a recent study out of Lancet Neurology really kind of was quite interesting in looking at autoimmune encephalitis, but it was actually associated with prior HSV encephalitis. And so this is kind of really, perked up a lot of people's thoughts about, okay, so now not only do we have to worry about the kind of immediate infectious cause, but what are some potential complications of the infectious encephalitis? And so this was a Spanish cohort. There's a couple of different cohorts. One was looking at 50 patients who had HSV encephalitis over a 4-year period. These patients had encephalitis and then ended up developing a secondary autoimmune encephalitis. And if they looked for antibodies to those immune markers, you were finding NMDA receptor antibodies in 2/3 of cases. There was another cohort of patients who looked at patients who, so the first cohort, patients got better and then developed a secondary encephalitis. These second cohort were patients who, were adequately treated but kept on getting worse. And 90% of those patients, of those 50 patients who had continuing worsening of symptoms even after their diagnosis with HSV encephalitis, even though they were on therapy, 90% of them had antibodies to some neuronal surface antigen, and again, 75% of which were NMDA. And so this is really going to start turning things on their head and thinking about the whole process. It used to be, okay, we have our diagnosis, we're done. Now we have to think of, okay, what are the implications of the diagnosis that we get? So how do we get to that diagnosis? The detection of bacterial meningitis and encephalitis is still pretty straightforward and still done largely the way it has been for the last 50 years. There are some improvements in technology that we'll talk about, but for the most part, it's about concentrating your sample, putting it onto solid media, performing a gram stain, ideally with cytocentrifugation to concentrate the organism on the slide for viewing, and letting the culture grow. However, can we improve our job? Can we do a better job of detecting bacterial meningitis and encephalitis? If you remember to some of the figures at the beginning of the slide, again, maybe 15% of cases, maybe, that's on a good day, are we getting positive, actionable bacterial meningitis encephalitis results? Now, some of that's just because it's not causing the disease, and some of it is because of poor methods. So this study looked at about 1,300 samples that were inoculated into both onto agar plates, as is kind of traditionally done, and into blood culture bottles. So this is something that's commonly done in the microbiology lab in terms of other sterile fluids, joint fluids, pleural fluids, things like that, where there's fluid that's inoculated onto a solid agar, but also into blood culture bottles to enhance detection. They had 70 samples which were positive only via the bottle. So, if you look at the chart at the top, you had 74 which were detected by both the agar culture and the blood culture. You had 7 which were detected only by the agar culture, and 70 again which were detected only via the bottle. And chart review considered 30 of them to be either definitive or probable infections. And includes things that, again, are pretty hard and fast you would consider a true infection. Things like Candida, Enterobacteriaceae, and Staph aureus, things which, if we think from an organism standpoint, are definitely, known causes of meningitis. There was another study that looked at a different bottle manufacturer with similar findings. The other question is, can we do identification faster? So molecular methods is one way to do identification faster, but it's not the only way. And so this particular study looked at, could we actually use MALDI-TOF mass spectrometry on positive spinal fluid that was positive by gram stain. So the idea being that if there's enough organism to make a gram stain positive, you might be able to actually do MALDI-TOF directly on the sample and get a positive result. It was a small study looking at 44 samples. What you see is that gram-negative rods, it actually wasn't too bad. 17 out of 21 gram-negative rods were correct. There was one incorrect identification and 3 no identifications. For other gram stain reactions, other organism groups, gram-positive cocci, yeasts, it just was not a great test. There wasn't necessarily a lot of useful information coming out of it. In the case of gram-positive cocci, 1 out of 20 was correct, but 2 out of 20 were incorrect. So you actually were more likely to get an incorrect result than a correct result. So it's an interesting publication. It shows some potential, but clearly it's not the answer. Fungal meningitis, we have a number of diagnostic modalities beyond culture to look for fungal meningitis. We can do staining techniques such as India ink, though that is rarely done in labs in the United States anymore. Very commonly performed are antigen-based tests such as the cryptococcal lateral flow or latex agglutination tests. And then we can actually use biomarkers such as beta-1,3-glucan and to see if there is other fungi present. All right, so one of those markers, which again is a very good biomarker, would be beta-1,3-glucan. And in this case, we're talking about the Exserohilum infection, the Exserohilum outbreak from a number of years ago, which was associated with patients who received contaminated steroid injections. These were contaminated at the point of manufacture with Exserohilum mold. What you can see from this chart is that patients who were culture or PCR positive almost uniformly had beta-1,3-glucans greater than 230 picograms per mil. On the other side, your control subjects, again, very rarely did they have high positive beta-1,3 markers. If you look at the actual breakdown of patients, again, who had meningitis with this infection, a large percentage of them had high-level beta-1,3 beta-D-glucan markers. And so it's just showing how patients and how these other kind of markers could be used in a case where it might be otherwise difficult to make a diagnosis. Viral meningitis and encephalitis is another area where the diagnosis is quite difficult. And so this is looking at a 3-year period in China, looking in children for the diagnosis of viral and meningitis and encephalitis. What you can see is that they had a large number of viruses that were implicated in meningitis and encephalitis, but they also had to do a number of different tests. So if you look down at the bottom, they did a PCR test for enteroviruses. They had a multiplex test for herpes viruses, which included HSV, VZV, EBV, CMV, and HHV6. They did IgM testing in the CSF for Japanese encephalitis virus. They had serum IgM tests for other things such as tick-borne encephalitis virus, dengue, mumps, and rubella. So this, not only shows the diversity in terms of viruses which can cause meningitis and encephalitis, but also how difficult it can be to make that diagnosis. So if we talk a little bit more about molecular diagnostics for meningitis and encephalitis, there's really 3 different bins that we can think about. We can think about the targeted PCRs. So there's FDA-cleared tests for HSV, VZV, and enterovirus. There are lab-developed protocols for pretty much any other pathogen that you can think of. You can think of multiplex panels for which there are both CE and FDA marked options. And then what's kind of emerging and now coming to market in terms of lab developed testing is next generation sequencing or metagenomic analysis. So to focus on the panels, as I said, there are two panels. One is CE marked from Fast Track Diagnostics, which has a variety of different kits. One looking at viral meningitis agents, one looking at agents that cause bacterial meningitis, one associated with neonatal meningitis, and their so-called Neuro 9 panel, which is kind of a specialty panel for viral causes of meningitis. In this particular study was an evaluation of about 480 CSF samples with the bacterial and Neuro 9 panels, a 21% positivity, a large number of enterovirus and adenovirus in this particular cohort, and a large number of Streptococcus pneumoniae. One of the things which you'll note is a general concern when looking at molecular targets for bacterial pathogens. You can see that only 7 of 14 Streptococcus pneumoniae and 1 of 8 Neisseria meningitidis were recovered in culture. So part of this might be the fastidiousness of the organisms and the difficulty in recovering the culture in general. Presence of prior antibiotics can also play a role in low rates of recovery, but the other concern is always the potential for false positives. In the U.S., many people are familiar with the film-array meningitis and encephalitis panel, the ME panel, which was FDA cleared in 2015 for the detection of 14 targets directly from CSF, which was obtained by lumbar puncture. You can see the targets present on this panel: E. coli, Haemophilus influenzae, Streptococcus pneumoniae, Listeria monocytogenes, Streptococcus agalactiae, Neisseria meningitidis, the viruses, herpes simplex virus 1 and 2, enterovirus, human herpes virus 6, varicella zoster virus, human paraechovirus, and cytomegalovirus, and then your fungal target of Cryptococcus neoformans and Gaudii. When we look at the performance of the meningitis encephalitis panel, it was really quite good in the multi-center evaluation, but there were some things that were very interesting to know. One of which was, again, owing to the difficulty of making a diagnosis of meningitis or encephalitis, and that there were a number of times in which the ME panel had a result which was different from the comparator test. So be it culture, be it PCR, there was a difference between what the ME panel said and what the kind of standard of care testing had described. And that after doing some type of discrepant analysis, where did those fall out? What was interesting is that if you look at the table here on the right, kind of the vast majority of issues are quote-unquote false positives, meaning things that were detected by the film array that were not detected by the kind of the routine testing or the comparator testing. So there were 43 cases, or 43 times where the film array panel picked up something that the kind of routine testing did not. There were only 6 instances where the routine testing picked up something that was not picked up by film array. What you can see in terms of the results is that in terms of the ones that were missed by film array initially, kind of arbitration and discrepant investigation, most of those were truly false negatives, and that a limitation to bear in mind for that testing. When it came to the positives, so the extra detections by the panel, what you can start to see is that it's really much more difficult to sort out. There were definitely cases where what was picked up by the panel was of benefit would have been of benefit to the patient, things that were not originally described as being in the samples that were arbitrated to be kind of the true result was the presence of that analyte. However, equally as often, that analyte was deemed to be a false positive. So it can be difficult to determine how do we actually go about evaluating the significance of some of these positive results when an extra detection could equally be a false positive as it could be a true positive. What we know is that from archive samples, again, for the vast majority of targets, the film array performs extremely well. There are some targets that we need to keep an eye on, so things like HSV and Cryptococcus neoformans and Cryptococcus gaudii, and for which I'm going to go through a few cases which have kind of illustrated some of the concerns and some of the limitations of panel testing with kind of a broad use approach. So, in 2018, Chu et al. Described 2 cases of Cryptococcus neoformans that were negative by the ME panel, but positive by cryptococcal antigen in culture. In one instance, the patient was actually sent home and had to return upon growth of the bug. In the other case, the physician taking care of the patient actually requested additional testing, and one of which was cryptococcal antigen, which was positive. And so there really was no change in the management of that patient. In 2017, there was a report of a positive HHV6 in a kidney transplant patient. Importantly in this case, you can see, where the overall utilization of this test falls into it. So there was a panel test sent, there was a bacterial culture sent, but there were no fungal or AFB studies. Once the patient deteriorated, then they started doing additional testing, including additional studies for fungal and AFB, and now that included the cryptococcal antigen. And that's when the patient started to improve once they were placed on appropriate therapy for cryptococcus. So just because the targets are present on the panel, again, it's important to realize the limitations of any approach, and that these tests are not, in some instances, these tests are not a replace for the current methodologies in use. One of the probably the more famous cases was where a positive HSV1 on an ME panel kind of delayed the diagnosis of Mycobacterium tuberculosis. So a test, an organism that's not even included on the panel, would not readily be available and could not necessarily even be suspected. But testing was delayed because of the positive result initially. So if we think about all of these cases, the initial testing significantly altered the patient management. So that, in some respects, that's good. What we want is to be doing diagnostic tests that are causing action in the clinicians. Otherwise, why are we going through the effort of performing those tests? In a lot of these cases, there was continued decline in the patients, and they were transferred to different institutions or had different providers evaluate their care. Ultimately, it was skepticism of panel-based results that led to additional testing via other modalities or searching for additional pathogens. So it really begs the question, for some of these, what does a positive mean? And so if we think about things like common viruses, something like HHV6, what does a positive detection of HHV6 really mean? And I think the answer is we don't really know. So in this study, from a number of years ago, 2001, a number of years ago, it looked at the presence of HHV6 in normal and neoplastic brain tissue. So thinking something that has nothing to do with infectious encephalitis, infectious meningitis, but just looking for the presence of the virus. And what we can see is in that about a third of cases either being metastatic, or not metastatic, neoplastic brain tissue or in normal brain tissue, we're finding presence of HHV6 DNA. And so this really, again, begs the question of what is the significance of a positive result for this particular virus. This extends to other herpes viruses. So in this particular study, they're looking at patients who were classified as having either tick-borne encephalitis or enteroviral meningitis. And you can see that even in those cases, again, you find a smattering of herpes viruses popping up. HSV1, HSV2, VZV, HHV6, sometimes even multiple viruses, HSV6 and VZV. So what does this all mean? I don't think we quite know yet. So in some cases, is it possible that these patients have infections with multiple viruses, or they're reactivating some of their herpes viruses, and it actually is of benefit for them to receive something like acyclovir? It certainly may. but it really just emphasizes the fact that we're very early in understanding the kind of the diagnostic implications of testing this group, because for so many years it was so difficult to identify an etiology for these diseases. So one approach which has really started to pan out is looking at what's your pretest probability. So in this particular study out of Lancet Infectious Disease from a couple of years ago, it looked at the probability of diagnosing meningitis and encephalitis in a patient who had a low white blood cell count in their CSF. So in this study, they had 457 patients who had a low white blood cell count in their CSF. Only 3 had positive results. 1 was a Cryptococcus neoformans in a patient who had who was HIV positive. And in 2 other cases, the immune status is unknown. So these could have also been immunocompromised patients for which we expect doing some type of selective testing may not be of benefit. The idea of selective testing and the value of selective testing goes back a little bit further to this study out of WashU from 2015 that looked at kind of the overall prevalence of viruses in their institution. So in total, they looked between 2008 and 2012, and they found somewhere between 1% and 2% of their virus testing in the CSF was positive. And this is the sort of thing that we see across the board, is that the diagnosis of viral encephalitis is a rare event. And so they looked at what were some of the parameters that may help predict the positivity of these patients. And you got a kind of a smattering of results. So for the CSF protein, you can see that in HSV and VZV, the CSF protein was more likely to be elevated than in the positive patients than in the negative patients, but that didn't really hold true for CMV or EBV. If you looked at glucose, you may see a decrease in glucose for HSV, but you're not really going to see a change for the other viruses. If we look at the cell counts for red blood cells, again, HSV, there was kind of a trend towards more red blood cells being present for HSV positive cases than HSV negative cases. Same thing with VZV, but again, not super solid in terms of, okay, we can really hang our hat on this parameter as some way to read this out. If you look at the presence of white blood cells, however, that's where you start to see a more profound impact in terms of, or a more profound difference in terms of the difference between what you see in positive versus negative cases. So, in HSV, you can see the vast majority of patients who were HSV positive had a high nucleated count, and those who were negative had a very low nucleated count in their CSF. And that actually held true for all the different viruses that they were looking at, so HSV, VZV, CMV, and enterovirus. The other thing that they looked at was, did time of year matter? So we know that especially for something like enterovirus, there is a season to enterovirus, typically peaking in the US in the kind of somewhere between July and September timeframe, late summer, early fall. And you can see here that is indeed where they saw the peak of their enteroviral activity was in the summer timeframe. And so if they implemented selective testing, they're going to set unique criteria. And so this group set criteria at greater than 10 white blood cells for an immunocompetent patient, understanding that if the patient were immunocompromised, it may be hard to mount the response that you could actually see in the CSF in terms of like a white blood cell count. They also limited enterovirus testing to seasonal testing, so they only tested during April to October for enterovirus. And what they found is that they saved about $60,000 annually by doing this selective testing. And not only did they end up saving money, there were actually fewer requests in general. And so you can see that just looking at the numbers requested, just having some type of conversation about the potential value of testing and having some type of diagnostic stewardship or algorithm in place reduced by somewhere between 8 and 20% the number of tests even requested. So it really shows that this type of stewardship has impact and has value. And one kind of last caution for widespread testing. And so this was a study that was done at a tertiary care hospital. It was a 10-month study where they essentially allowed widespread testing of meningitis and encephalitis panels during that time period. This is one of the concerns. Only 70% had a clinical suspicion for CNS infection. So in 30% of cases, there was actually not a high level of clinical suspicion that could be ascertained from the chart for an infection. Yes, the patient had a CNS process, but there was not a suspicion for infection, which kind of follows if you look at the number that were receiving empiric antimicrobials for infection. Kind of again, only 60% were receiving empiric antimicrobials for CNS infection. And so really the question at that point is why are you doing the test? If you do not have the pretest probability, no matter what the test is, should you be performing that test in an absence of a suspicion of infection? Very low numbers tested positive, so 6.4% or 45 patients. And of those positives, nearly a quarter were determined by blinded review to be clinically insignificant. So again, the caution of widespread unchecked testing of any type, especially for a disease state or disease states which are poorly understood, could really lead to some problems. That being said, it is a diagnosis that is fraught with complications. So I just presented data about how you should use pleocytosis in the CSF to help limit testing. That goes out the window when you're dealing with children. So the idea that CSF pleocytosis is predictive of infection is not true when you look at patients who are less than 12 months of age. So in this study, there were a number of patients, who were less than 12 months of age, who had positive PCR results without any evidence of pleocytosis. And so it's important to know that epidemiology changes. And so if you look at, for example, the cell count performance down there at the bottom in the infant cohort, the negative predictive value of the cell count was 71%. So again, a very poor test to look at cell count as your main predictor for a PCR positive result. This is another study showing the same thing, looking at, again, pleocytosis in positive results in children. In this particular study, they used a white blood cell count of 9 as their definition of pleocytosis. And again, although you have a number of normal negatives with pleocytosis, you do have both bacterial and viral positive cases that had normal cell counts by the definition of less than 9 cells per ml. And so again, it is something that needs to be aware of, and that, again, children and adults don't always follow kind of the same pattern. One thing that is quite clear, however, is that the impact and value of rapid testing. So regardless of whether you're testing one target or 20 targets, the ability to do testing faster has a positive impact on patients. And so this is a retrospective study looking at Children's Hospital in LA, looking at 360 cases of negative HSV testing. So again, here we're just talking about negative results, not even the positive results. But if you have a test with good negative predictive value, you can do things like de-escalate antibiotics or discontinue antibiotics such as acyclovir. So in kind of the pre-period, where batched LDT HSV testing was performed and took a median of almost 24 hours, they were able to reduce that to 9 hours once they had some sample to answer HSV testing solutions in place. So not only did they reduce the time for test result, they also reduced the time in acyclovir usage. And so in children and in adults, being able to reduce the amount of antimicrobial exposure is really one of the kind of hallmarks of active stewardship and ways to help improve patient care. We know that having a diagnosis helps. And so this is the same figure that I showed at the very beginning of the presentation, looking at kind of the breakdown of different causes of meningitis and encephalitis, but also what the identity or what the impact of having a diagnosis was on antibiotic, antiviral, or antifungal therapy. So you can see that not only like in the children's LA study, could a negative result be helpful, but a positive result can also be helpful. So if you look at the idea that someone who has an unknown etiology for meningitis or encephalitis is going to get 5 days of antibacterial therapy, whereas if they have a positive enterovirus, they may only get 3 days of antibacterial therapy, that's a significant improvement. Again, reducing that antibacterial exposure, reducing some of that selective pressure, the likelihood of developing other infections such as C. difficile. Again, we can all talk about the benefits of reduced antimicrobial therapy. We know some of the issues with antifungal therapy and some of the toxicities associated with antifungal and antiviral therapy. Again, being able to reduce that burden by having some type of positive result impacting those days of therapy is very valuable. But ultimately, the current diagnostic tests are insufficient. And so again, this is showing another figure that I had at the beginning of this study where we pointed out at the bottom, depending on what you're looking for, depending on what your metric is, somewhere between 60 and 80% of cases of meningitis and encephalitis are unknown. We do not know what that etiology is, so we can't refine testing. We can't simplify antimicrobial therapy. And we really need to figure out what to do, and that's where next generation sequencing comes in. And so I'm only going to have one slide on next generation sequencing, and it's really just to demonstrate some of the power of metagenomic sequencing from a number of cases that have come out of the CHU lab, looking at identification of unknown organisms or not thought of organisms by using metagenomic next generation sequencing in patients who have meningitis or encephalitis. This is an excellent tool, but what's the ability to do this on large scale is still somewhat unknown. And these are the positive cases are the ones that are getting the headlines. There's still a large number of these cases that are negative. Just because there's the presence of this test doesn't mean that it too does not have all the answers. It too suffers from some of the issues of other testing methodologies where if the virus or pathogen isn't present, it can't detect it. And that sometimes you do need multiple different modalities. You do need serologic testing to diagnose arboviruses, things like that. And so it's a great start, and I think a great the diagnosis of meningitis and encephalitis is a great place to really look at this testing and kind of refine this testing, but it is certainly not going to be the answer or the only test that we need for this disease. So in conclusion, hopefully I've established for you that the diagnosis of meningitis and encephalitis is a complex and multifactorial process, that there is really no one best test yet, that improvements can still be made for all of our diagnostic modalities, and that most importantly, it's a great area for diagnostic stewardship. So for very few disease states are there kind of such profound studies showing the impact of potential diagnostic stewardship in terms of escalation of antibiotics, de-escalation of antibiotics, the ability to use other less expensive and quicker laboratory tests to determine what to do, and the impact of pre-test probability in terms of the ability to act on positive or negative results. So with that, I'd like to thank you very much. If there are questions, there is ability to email questions to the program. and I will certainly answer those that I can or point you in the right direction. So thank you very much and have a wonderful rest of your day.